This is Patricia Walter. It's December 3, 2012, and I'm in Columbia, South Carolina with Dr. Gross. Hi, Dr. Gross.
Hello, Pat. How are you doing today?
Good. Dr. Gross has done over 3,000 hip resurfacings.
That's correct.
And today we want to talk about why a prospective patient would want a hip resurfacing compared to a total hip replacement.
Yeah, Pat, that's a huge question, and it continues to be one of major controversy in orthopedics. Hip resurfacing is really quite a different operation than a hip replacement. On a very basic level, it's similar because you take an arthritic joint and you put new artificial surfaces on the joint and get rid of the pain and let people walk again. But that's about where the similarity with hip replacement ends. Hip resurfacing is a totally different operation, and it has several major advantages to hip replacement. Number one, foremost among them, is function. So the patient who is not very active and just does day-to-day activities and does a little walking and so forth, if they had a hip replacement or hip resurfacing and you didn't tell them which one you did, they wouldn't be able to tell the difference. Functionally, it's the same. Their pain would be relieved, they'd walk around normally without a limp and be able to do all their daily activities. But if you're looking at a patient who wants to be athletically active, that's a whole different story. The hip resurfacing is much more like a normal hip functionally, and there have been numerous studies that have documented that, and a total hip replacement doesn't really match up to that. So if you're talking about, for instance, these baby boomers who are now in their 40s, 50s, and can no longer play sports, and they want to continue sports, they have an arthritic hip, and that's what's limiting. They go to their orthopedic surgeon, he tells them they need a hip replacement, and then they have to stop playing tennis, they have to stop running, they have to stop skiing, all these things they have to stop doing. They can't get in a kayak anymore and bend their hips so far. So all these things are out. If you have a resurfacing, you can do all those things. And there have been 4 or 5 different gait studies that have analyzed gait. Now, when people walk normally, walk just down the street, you can't tell the difference if they've had a resurfacing or total hip. But if you put fancy electrodes on them and put them in a gait lab, the resurfacing functions just like a normal hip. The total hip replacement doesn't. There is a functional difference. And there's also been 2 very interesting survey studies done, one by Robert Barrick in St. Louis and one by Phil Noble, and 2 independent studies that tried to assess the level of function patients got to. And basically the studies were designed such that they took patients young active patients who wanted to return to athletic activity, and then they evaluated them after either a hip replacement or after resurfacing and tried to figure out did we meet their goals. And the hip resurfacing, there was a vast difference. Many more patients who had the resurfacing were able to go back to high-level activities, impact sports, and those with a hip replacement had a much lower rate of being able to go back to those activities. So that's just briefly a summary of the literature on the function of a resurfacing. If you want to go to impact sports, you have to have a resurfacing. You can't really do that with a hip replacement. Now, there are examples of people who can, but statistically, you're much more likely to be able to do it with a resurfacing. So function is one major difference. It's a totally different operation. It turns you more towards what a normal hip is. The other is bone preservation. If you're young and you're likely to need another operation at some point, if you're, say, in your 40s and 50s, when you have this resurfacing or total hip, you're likely to need another operation sometime. If you do an operation that preserves bone, it's just logical that that's a better way to plan for the future. Number 3, hip resurfacing is a stable hip. A total hip replacement is an unstable hip. It's mechanically unstable because you put a smaller ball in than the natural hip. So that makes it a biomechanical compromise. Now, there's the field of total hip replacement is quite varied. There's smaller bearings, larger bearings. There's controversies and pluses and minuses between all of those. But let's just take the standard total hip, which is a 28 millimeter bearing size. That carries about a 5% dislocation rate, and about half of those dislocations end up having to be revived, need a reoperation because they come out over and over again. They become recurrent dislocations. In the 3,000 resurfacings I've done, we have a 0.25% dislocation rate, and only 1 patient has ever had to have a revision so far for recurrent instability. 1 out of 3,000. There's a drastic difference there between 5% instability and 2.5% revision rate compared to 1 out of 3,000 for stability. So On the basis of stability, resurfacing is a clear winner. So you have better function and you have markedly better stability. Third, and we talked about third about bone preservation. And the final thing is thigh pain. About 3 to 5% of patients with a stem down to their femur for a total hip end up feeling that stem, and it limits their activities. And so that's what we call thigh pain. You don't get that with the resurfacing. So those are the 4 major benefits of resurfacing. Now we'll go to the flip side. I also do hip replacements, although I'm very biased towards resurfacing because I think it's a more normal hip, and that's the way it should be done in a younger person, in my opinion. But the 2 major negatives for resurfacing are femoral neck fractures, which can't occur in a total hip because you cut the femoral neck off. It's gone. And the second one are these reports of metal wear failures, and we'll address both of those. Femoral neck fracture is about a 1 to 2% incidence in most studies of hip resurfacing. There are some as high as 10%, and there are some as low as 0.1%. So there's a big range, but on average it's about 1 to 2%. When I started resurfacing, my rate in the first few hundred was about 1.3%. We've learned how to treat patients differently, basically looking at their bone density and not excluding patients with weaker bone, but treating them differently after the surgery. And we've managed to now reduce, in the last 500 cases, our rate of dislocation to 1 out of 5, in the last 500 cases, we've reduced our fracture rate to 1 out of 500. So that comes out to a 0.2% incidence. So in my hands now, the fracture rate is 0.2%. If you look all across the board, it's 1 to 2%. Then if you look at a similar complication with hip replacement, you can get a fracture of the trochanter or the shaft of the femur when you put that stem in or during the healing process of a total hip, and the incidence of that is about 0.7%. That's according to a major study done about 4 or 5 years ago by Dr. Larry Dorr and the Mayo Clinic, a huge combined series, and they found an incidence of 0.7%. So now if you just compare my rate of femoral neck fracture, 0.2% to that, you can see that problem with resurfacing basically has been solved. It's no longer a higher risk of fracture. It's actually a lower risk of fracture than a total hip replacement now in my hands, and possibly also in the hands of other experienced surgeons who've learned to deal with this risk better. So femoral neck fracture was a criticism of resurfacing. I don't consider it a significant risk factor anymore at all. The major problem that we're trying to solve, and I think we're just about done solving it, is this problem of metal wear. Again, this is a problem that has been reported at quite a different incidence from institution to institution or surgeon to surgeon. On the high end, we have the results out of Oxford, about 4% wear failure at 8 years, and that's a time-weighted failure rate. My failure rate overall from this problem, adverse wear, is 0.3%, and if you time-weight it to 10 years, it's 1%. So 1% by 10 years. And all those patients, interestingly, with ones with smaller implant sizes, and most of them women. And so many other studies have shown similar types of things, that women are higher risk and patients with smaller implant sizes are higher risk. And so the simple solution seems to be just don't do women or just don't do patients with smaller implant sizes. I disagree with that philosophy. I think that what you need to do is look a level deeper. So we know those are the problem patients. The question is, why are those the problem patients? And the explanation really is quite straightforward. It's because in most implant systems, the smaller implant sizes, so you have a range from the smallest to the largest, the smaller implant sizes have less coverage arc by design. It's just a quirk of design of these implants. And so at a given cup inclination angle, they're much more prone to be subject to what's called edge loading and this runaway wear problem. That's what's going on when these people have these wear failures. So the solution is either don't do those smaller sizes or just be sure to put that socket component in a more flat and a more horizontal position. And we've just presented a major paper on this at the International Society of Technology and Arthroplasty and won an award for that. We've basically come up with a safe zone for placing components. So we know the angle to put a small component and the angle to put a big component to avoid this wear failure. And if you follow our guidelines, the problem of adverse wear should be completely eliminated. Now, it usually takes 2 to 4 years for this to present itself after surgery. It's not something you see within 3 months or 6 months. So there's a lag period. Once you start instituting these new guidelines of how to place cups according to our research, then you have to wait 2 to 4 years, do metal ion testing, and then you can confirm that you've actually resolved the problem. So we're in the process of that right now. So first of all, we found a set of guidelines on how to avoid the wear problem from an analysis of over 1,000 patients with resurfacings and metal ion levels. And now we're instituting, for the last over a year, we've already instituted these guidelines. And so in a few years, then we'll see if we can confirm the fact that these wear failures can actually be avoided by placing the component in certain positions. So in the past, we've had these guidelines that came down to us from total hip replacements, which are very inaccurate and vague about how to place a socket component. And now we've come up with a very much more specific set of guidelines for hip resurfacing. And if you follow our data, it should allow us to completely eliminate the wear problem. So number one, it's an unusual problem to start with in the hands of a experienced resurfacing surgeon. Again, my failure rate from this is 0.3%, and I'm not the only one. DeSmet, McMinn, Amstutz, the Canadian group, all have published data that the wear failure rates are well below 1%. So there's one major group that has extremely high wear failure rate, and then there's all these other groups that have published very low wear failure rates with well-designed implants. Now there's one other caveat, and that is the DePuy ASR implant. Whoever used that implant has a very high failure rate because that had an inherent design flaw, which was a shallow wear cup basically, and that led to a higher rate of wear failure. So anyone who publishes on the DePuy is going to have a very high wear failure rate. So those would be the pros and cons of hip resurfacing and total hip as I see them on the pro for resurfacing, and then the negatives of resurfacing, which I've just addressed. I think we're well on our way to solving those problems.
What's the difference in longevity for the devices of hip resurfacing devices versus a total hip replacement? Some people think that it won't last as long as a total hip replacement.
Well, that's very difficult to say because there's no good randomized controlled studies comparing the two. And they're really apples and oranges. A resurfacing is a device we use for young people who want to go back to impact activities, and total hips are put in primarily in older people. So if you look at one study compared to another, they're a totally different group of patients. In the past, total hip replacement has performed very poorly in the young active patient. And if you go back to traditional hip replacements with standard polyethylene, it had carried back approximately a 80% survivorship rate at 8 years. Okay, that means about 20% failures by 8 years, most of it due to plastic wear. Now we have all kinds of newer devices with newer bearings, total hips with better plastics, the cross-linked polyethylenes, with metal bearings, which have gone through a phase of acceptance and now have declined, and the ceramic bearings. All these modern bearings have better wear characteristics than the standard polyethylene, and their durability should be much longer. We're getting the first reports in on the 10-year survivorship of these newer bearings, and they seem to be about 95%. And in the hands of experienced hip resurfacing surgeons, that's what you see for survivorship of hip resurfacing as well. But again, I've got to caution you, these are different groups of patients. The total hip patients tend to be older and tend not to be involved in impact sporting activities. And that's a key difference because that leads to implant deterioration, right? So you don't really have an accurate comparison. But I'd say overall it's about 95% survivorship.
I've had people tell me they believe it takes longer to recover from a hip resurfacing than a total hip replacement surgery. Could you talk about the pros and cons?
I don't think that's true. I do both operations. I do about 90% resurfacing, about 10% total hips. But I can't see any difference in the recovery. It's more about the other things you do around the surgery that determine the recovery, not which implant you put in. If you do minimally invasive surgery, I mean, sometimes some surgeons do hip resurfacing, do them through a 12-inch incision. Well, that's going to hurt a little bit more, and it's going to take a little longer to recover. There's no doubt about it. But I do all of mine through a 4-inch incision. I've been doing it for years. So minimally invasive surgery. Good blood management, so the transfusion rate in this country is about 20 to 30% for hip replacement. I haven't transfused a patient over 1,000 cases. So that makes a difference with total hip or resurfacing. That's going to speed up your recovery if you don't lose a ton of blood and you don't need to be transfused. Good pain management protocols, using a multimodal pain management system makes the patient feel better, they get up quicker, they move around quicker, their recovery is quicker. So it's blood management, it's pain management, it's minimally invasive surgery. Those affect the speed of recovery, and those can be done with both operations, and I do it for both operations. I think many surgeons who are inexperienced with resurfacing have to make gigantic incisions just to be able to do the operation because it's more complicated, and perhaps in those cases the recovery would be possibly longer.
The one other thing that people ask me, they say they have allergies to nickel, or perhaps they feel they have other allergies, and so they're leery about any of the metal-on-metal devices. Are there tests, or is there a way they can tell whether a resurfacing or metal device would be all right for them?
No, there's no way to tell. The whole question of allergy is basically unproven. So we've just spent some time talking about metal wear problems. So let's just start with that. That's a definite problem. Metal implants put off metal particles, cobalt and chromium chiefly. Metal plastic or ceramic plastic bearings put off plastic particles chiefly, and that debris goes into the body. And ceramic bearings put off ceramic particles. Those go into the body has to deal with them. With well-designed implants that are placed well, the wear rates on all these implants are extremely low, and the amount of debris that your body receives is very small, and it can deal with it. The problem is particularly for metal bearings, if the cup is placed too steep, you get edge loading, you get an accelerated rate of wear, then the body gets overloaded with metal and it reacts to that. That's not an allergy, it's a particle overload problem, right? It's not an allergy problem. And if you take that implant out and put it back, put a cup in a better position, or even put another metal device in, I've done that numerous times, the patient does fine. They don't have an allergy to the metal, they've just been overloaded with particles. Same thing happens with a plastic bearing. If you have the old-fashioned plastic bearing, you put the cup too steep, and the patient is a young active person, they get tons of polyethylene debris, lots of bone is destroyed, and it's not an allergy, it's just the particle load is causing a problem for the patient's system. There are allergy tests, and there's two types of tests. There's a skin test, which is a way for testing for skin sensitivity. So this comes up typically in women who have a reaction to cheap jewelry. Cheap jewelry often contains nickel. A lot of people have skin sensitivity to nickel, and this test correlates with that skin sensitivity to nickel. It does not correlate with problems with a metal bearing implant in your body. These cobalt chrome implants do have a trace of nickel in them because the nickel comes in the alloy and you can't get it out. So there's some suspicion that people might have a reaction to nickel, but there's no way you can test for it. And this is why I say that. The wear problems are an identifiable problem of too much debris in the body. But if you test people with a skin test, with well-functioning implants, about 20% of them have a positive skin test, and they have no problems with their implant. And if you go in the general population, you test them, about 20% test positive. So as you can see, the test is of no value. It doesn't pick up people who are going to have problems with an implant. So we would say it's not a clinically valuable tool. It has no bearing on how you're going to react to the metal inside of your body. Then there's this set of tests called lymphocyte activation tests, which have been studied for at least a decade at a couple different centers in the world, and they've never been, they can show you a test and say you're reactive, have a positive test to nickel or to cobalt or chromium, but they've never published a study which has validated those tests. So just because you have a positive test on the lymphocyte reaction test doesn't mean you're going to have a reaction or not. It's never been shown. So it's a research tool. It's never been validated as a clinical tool. It doesn't help us in detecting if someone has an allergy or not. So how do we think about allergies? Well, I think if it happens, it's an extremely rare problem. There's no way to test for it. So if the patient doesn't have an adverse wear problem, and they don't have a loose implant, they have no other source, and they continue to have pain, perhaps they have an allergy. But patients with plastic implants have unexplained pain sometimes. Patients with metal bearing implants do. And there's no study that shows that one particular implant has a higher rate of unexplained pain. So you could call unexplained pain allergy. That's a questionable concept in my mind.
Well, I think that's a great summary for people that would like good information from an experienced surgeon about hip resurfacing versus total hip replacement. And I would assume you agree with me, the best place for a prospective patient to get that information would be from an experienced surgeon, not just reading the media or looking at information just on the internet.
There's a lot of good information on the internet. The media is a terrible place for the print media or television media is a terrible place for good information. They tend to exaggerate and try to instill fear in people to sell their media, and it's not a very good place to get information. But reading the actual papers themselves is a complicated task if you're not an expert in this area. And there are papers on both sides of this equation, some that show very low rates of wear failure, some that show high rates of wear failure, and there's a lot of intricacies in the whole thing. So speaking to someone who's really experienced in hip resurfacing is going to get you a biased answer, of course, towards hip replacement, but it's probably going to be scientifically valid or accurate information.
Well, thank you. I think you've answered a lot of questions for prospective patients.
Thanks, Pat.